This patient had a very poor response to chemo, which quite frankly is not uncommon. Chemo really does not have that much effect, in metastatic lung cancer. Normally I tell my patients about a third of the time you'll have response, a third of the time you'll have stable disease, and a third of the time it will progress. But really, even if there is response or stable disease, that's never long lasting. So this patient had the worst case scenario, progression on carboplatin pemetrexed, and that speaks to the reason why lung cancer has been such a difficult disease to treat, even with advances in chemotherapy. And this is the best tolerated and perhaps most potent chemotherapy we have for a non-squamous lung cancer. The outcomes are quite poor. So when this patient progressed on chemo, what are the choices? So one choice would have been immunotherapy. Granted, the PD-L1 status is 0, but the drug nivolumab and atezolizumab are both approved even in that setting. The other approach would be second-line therapy with docetaxel and ramucirumab. Some might give docetaxel alone. I would say you can make a strong case for docetaxel ramucirumab based on the REVEL study. And then some of the sub-analyses of the REVEL study that showed that the results, which favored the combination over docetaxel, were positive even in those patients who had rapid progression, such as this patient. So I think that all those would be possibilities. You've got to look at the patient's performance status. Are they a candidate for docetaxel or not? Having used docetaxel now for 20 plus years, it's a good drug, but it's a tough drug. It produces neutropenia and weakness and fatigue, so it is a tough one to give. So that's why many people are going to the immunotherapy right off the bat. Certainly in a case like this, now based on Keynote 189 data, one might have even given the immunotherapy earlier. And if that were the case, you wouldn't have that as an option. So then your option would be the docetaxel ramucirumab.